Bismillahirrahmanirrahim. Hopefully, everyone of you will be well. Beta, my topic today is about thyroid gland. Last time in the last lecture, we discussed about the anatomy and the physiology of the thyroid gland. So today we are going to start about the important diseases, uh, both in the thyroid gland and also in the parathyroid gland. But today we are going to start with the thyroid gland. Uh, like I said last time, what we are going to discuss today is about we are going to start with the thyroglossus cyst and fistula. And now coming to thyroglossus cyst. Basically, I told you in my last lecture, that the thyroid gland arises from the thyroglossal duct, and which arises from the foramen cecum. And as I told you, that the foramen cecum is at the junction of anterior two-thirds and posterior one-third of the tongue. So there is a thyroglossal duct, and it basically disappears when a person is born after the birth. But if the tract persists, and if it not disappear, if it's not being if it still persists, so it can result in a sinus fistula or a cyst. Now, how you differentiate between a cyst, a sinus, and a fistula? A cyst is a closed cavity or with epithelial lining surfaces having fluid. It's a closed entity, and a fistula is abnormal communication between two epithelial lining surfaces, and a sinus is a cavity epithelial lining with a single opening. So, if it's totally closed with the epithelial lining, it's a cyst. If it's an abnormal communication between two epithelial lining surfaces, is a fistula. And if it's a cavity with single opening with epithelial lining, that's called a cyst. Now, thyroglossal cyst is basically the persistence of thyroglossal duct, which should, in all the cases, normal cases, should disappear at the time of birth. But if it persists, so it can result in formation of a cyst in front of the neck. So, as you can see in the diagram here, that this is the foramen cecum here, and there it descends down in front of the hide bone and in front of the thyrocartilage. So the position where you can find a cyst is, it could be superior to the hide bone here. It could be just in front of the hide bone. It could be inferior of the hide bone, uh, in front of the thyrocartilage. Now, why I'm emphasizing on the hide bone? Because later when we are going to discuss about the operation of or the removal of the cyst, we are all, there would be a portion of the hide bone which we are going to take along with the cyst that we are going to discuss. So for you guys, so what the important points are, that why it happens, it's the persistence of thyroglossal tract. What important other structure is the foramen cecum, because thyroglossal tract descend from foramen cecum. It's an MCQ question which you can get in your MCQs. And where is foramen cecum? It is at the junction of anterior two-third with the posterior one-third of the tongue. This is another MCQ question. It can result in three things. Either it could be sinus. Sinus is a closed cavity with epithelial lining with a single opening. If a fistula, this is abnormal communication between two epithelial lining surfaces, like tracheoesophageal fistula. It's a communication between trachea and esophagus. Vesicovaginal fistula is a communication with vagina and urinary bladder. And enterocutaneous fistula is a communication between skin and the GI tract, any portion of the gut. And the cyst, I have told you, is a closed cavity with fluid with epithelial lining. How the fistula is formed? So in this case, the fistula would be between the foramen cecum and the skin. If it erupts on the skin, so there would be two epithelial lining. One would be of the foramen cecum, of the thyroglossal duct, and another would be of the skin. So abnormal communication between two epithelial lining surfaces or cavities is thyroglossal fistula. Uh, Now, the clinical features of thyroglossus, usually it's found in the subhyoid portion of the tract. Like I told you, this is the subhyoid between the hyoid. Usually, you find it in the subhyoid portion, like here. You can feel it. 75% present in the midline swelling, as you can see, it's in the midline. A reminder can be found the lateral aspect of the head bone. As in the previous diagram, I have told you that it could be superior in front or inferior to the head bone. So in 75% cases, it is a midline swelling. The cyst elevates on the protrusion of the tongue. Basically, this is a test to differentiate between a thyroglossus cyst from rest of the swellings of the neck. The classical signs, if someone asks you in your exam that how you differentiate between a thyroglossus cyst and another neck swelling like a thyroid gland or any submental lymph nodes, so you are going to say that we are going to perform the tongue protrusion test. Now, how you do the tongue protrusion test? Ask the patient to open the mouth and protrude the tongue, and you have to look on the movement of the swelling. If it moves with the tongue protrusion, that is a thyroglossus cyst. Why it moves with the tongue protrusion? Since it is attached with the foramen cecum, which is a part of the posterior part of the tongue. So when you protrude the tongue, so it moves forward outwards, and the thyroglossus cyst is being lifted up. So the main classical clinical sign of thyroglossus cyst is tongue protrusion test. What are the complication? There was a question 2 years back in your exam that how you how you identify thyroglossus cyst, what are the clinical features and what complications you get. So in the complication, it can get infected because of the lymphoid tissue in it. It can return into a thyroglossus fistula, or it can cause, in a very minor cases, it can cause some compression symptom if it gets infected and get enlarged to cause the compression. Now coming to the treatment, we can aspirate it, we can inject steroid injection in it, but there's a high rate of recurrence in it. Once we do aspiration, it can reoccur. So, what's the proper treatment? Is the cyst trunk operation. The name is the cyst trunk operation, and what we do, we give anesthesia, transfer anesthesia in the neck, always a skin crease anesthesia. Then we raise the platysma flap, do the dissection of this cyst, and how we do it, that we hold it, and then we have to take it all the way down to the foramen cecum, including one third of the hide bone. So till the foramen cecum. If we don't do it, so if any part of the thyroglossal cyst or duct remains, so there is a highly probability of getting it recurrence and turning it into a fistula. So mainly you have to do the dissection, raise the both the platysma flap, and then eventually you have to dissect it till the foramen cecum so that you can get it completely removed. This procedure is called cyst trunk procedure. They can ask you about the complications of this procedure, so you can narrate that in this procedure we can do the besides the anesthesia complication, we can we divide it into perioperative and postoperative complication. Perioperative complication is damage to the nearby structures like damage to the trachea, thyroid gland, and while dissecting to the hide bone, we can do the damage to the tongue and also the hypoglossal nerve and hypoglossal muscles. And post-operative complication, as I always broadly classify them in immediate post-operative and late post-operative complication, which I've already told you. So this was about thyroglossal cyst. If there is a small opening here, and then I can show you in the next diagram. So this is the thyroglossal fistula. As you can see here, that there is a discharging sinus at the base of the cyst here. So how this happened, that the cyst erupted on the skin. So this is a fistula which extends directly from here till foramen cecum. Now if this die you get in your OSPE, we do give this diagram in the OSPE. So sometimes the people write it that this is a diagram of uh, this is xylogram. So let me clear, this is not a xylogram. If you can see that this is a thyroglossal cyst which is extending into the foramen cecum. So don't confuse this diagram or this radiograph with the xylogram. It looks a bit similar, but it differs. So we do give this in your auspice. So this is a fistulogram. Now, what is fistulography? Fistulography is giving a dye in one of the opening and then taking a radiological image of that to see the extent. So we have given a radio opaque dye. You can see the opening through 10 cc syringe, and there you can see the cyst, and the track is going up to the foramen cecum. So this is how we are going to uh, detect the uh, uh, thyroglossal tract. So this was the other picture in which we can see. So this is one of the picture I have shown that the infected thyroglossal cyst. You can see the midline swelling, but this is red, and it means that it has got infection in it. Next one again in the midline swelling, thyroglossis. This is another picture of the thyroglossis, the big thyroglossis, in which I was saying that it can cause compression symptoms, and you can see this is a midline swelling which has enlarged probability. This is another example of an infective thyroid cyst. So this was a non-infected thyroid cyst, and this is an infected thyroid cyst. This is the anatomical structure in which we can say that how the hide bone is involved and at what portion we get this thyroglossal cyst. Uh, Now coming to the end of my lecture about the thyroglossal cyst. Now what questions you can get in your exam as a third year BDS student? As I have reviewed the last previous papers, so there were questions in auspice, and like there was a question like this. I have seen in the auspice case that they have asked that what is the this fistula tract, and how you are going to investigate in this patient, and what is the treatment and name of the operation. So this fistula tract is basically thyroglossal fistula. How we are going to investigate by fistulography, and what is the procedure is the cyst trunk procedure. So this was a brief answer that you are going to go to give in the OSPI. We do get a question in the exam almost in 2016, I think, and there was a question that 5-year-old child presented with the midline neck swelling which protrudes with the tongue, which protrudes from the trunk protrusions, which elevates with the trunk protrusions. It is non-tender, soft in consistency. So, what was the likely the diagnosis? The U answer should be thyroglossal. What is the embryological significance, or what is the embryological derivation of this thing? So you are going to say this is the persistence of the thyroglossal tract, and what complications occur in this. So you can say that it can get infected, it can turn into a thyroglossal fistula. And the fourth part was what is the treatment option. So you are going to say that we can go for aspiration, but in aspiration there are chances of recurrence. So the complete is the taking out the cyst up to the foramen cecum, and then this operation is called cyst trunk operation. So we do get questions in the exam about thyroglossis. You must have a clear idea about its position, its embryological history, and also the complication, and about the cyst trunk procedures, the significance of hide bone, the positions where the thyroglossus cyst can be found, and also about the complication of the surgeries. So, because now in the next lecture, I'm going to talk about the thyroid gland. So we'll take a short break now, and when then I'll be coming back after a short break of 2-3 minutes. So then we are going to start with the thyroid gland.